Welcome to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who's trying to figure out what to do to improve their health through listening to the news, by which I do not mean listening to the news will actually improve your health. I'm Matt Fox.
On the contrary.
I suspect it will harm your health. I'm Matt Fox, professor of epidemiology and global health, and I am here with Don Thea and Chris Gill from the Department of Global Health.
Hey there, Matt.
And we, as always, are broadcasting. I guess we're not broadcasting, we're podcasting.
No, we're recording.
Or fraudcasting. I don't know what we're doing. Now. We're casting.
We're casting our net wide.
From the Boston University Godley studio. So before we get started, we wanted to take a second to remind you about the Population Health Exchange, the Boston University School of Public Health's resource hub for lifelong learning. Find out more at www.pophealthex.org, where you'll find this podcast, as well as many other population health learning programs and tools. And I also wanted to make a special plug. The Population Health Exchange is having its Summer Institute again this year. It's the week of June 11th and June 18th here at the Boston University School of Public Health, where you can come and take courses in things like systematic reviews and meta-analysis or SAS course. It's a good time and much learning is had. So go ahead to the Population Health EX website and you can find out more information and register.
Can I make a request?
You can.
Can we change the music that leads into this
podcast?
I
like the music.
Yeah, I know, but we've had it for, 12, 15 episodes?
It's weird because like some shows will go on for years and years and years with the same music.
Yeah, I'd like to. I think we should start off with reggae.
I'm not even going to ask why. Not even going to go there.
I like reggae.
I'm not taking the bait. A reminder, go ahead onto iTunes or however you get your podcasts and give us a rating. That'll help other people find us. And now on to the show. So today in our first segment, which is our Journal Club segment, we are going to talk about a study that deals with the relationship between gluten in the diet and coronary heart disease. In the second part of the podcast, which is our deep dive, we're going to talk about what the role of prior evidence and beliefs should be when you critique an article. And then in our third segment, which is our amazing and amusing, we will get into some things that made us happy, or Don will give us an update on the Ig Nobel Awards. So, right. Let's get into it. So, segment one. So, we're going to talk about a review article, that looked at whether or not there is an association between a diet low in gluten and risk for coronary heart disease. So, the article was published in the British Medical Journal, and it is entitled "Long-Term Gluten Consumption in Adults Without Celiac Disease and Risk of Coronary Heart Disease: A Prospective Cohort Study," with lead author Benjamin LeBois from the Celiac Disease Center in the Department of Medicine at Columbia University College of Physicians and Surgeons. Before we get into it, I just want to make a couple of quick points about this study, which is, number one, I want to be very clear that this study specifically excludes people with celiac disease. So this is not provide any evidence for the role of celiac disease, role of gluten consumption and coronary heart disease among those with celiac, which is a totally different question you could ask. And I also want to be very clear that this study does not look at the effects of a gluten-free diet specifically. This is a study that looks at the amount of gluten in the diet and its relationship to heart disease. So with that on the table, Don, can you break it down for us? Tell us what the study was about.
Sure, Matt. Before I start, what I wanted to do is talk about a couple of things. One is the populations that this study is based on. One is the Nurses' Health Study. The other is the Health Professionals' Follow-Up Study. And I think it's worth mentioning these population cohorts because there's a tremendous amount of really important information that's come out of these two cohorts. They're run out of the Harvard system. And they've been going for really quite a long time. The Nurses' Health Study was established in 1976 to look at the long-term effects of birth control pills, smoking, on cancer and cardiovascular disease. And they enrolled 121,000 nurses. Massive group. And they have followed them with biennial questionnaires. Every 2 years, they send them a very comprehensive questionnaire. So it's all self-reported information. And they've been following them really until the present time.
And they're all nurses.
And they're all nurses.
As the name implies.
But important to note that not all nurses are women.
That's true.
It's often assumed that Nurses' Health Study is a women's study. That's not necessarily
not
true at all.
Right, of course.
Well, they went ahead and actually included in this analysis the Health Professionals Follow-Up Study, which is a prospective cohort of 51,000 male health professionals so that they would have good balance between the two. From all 58 50 states, and those subjects were enrolled in 1986. And as Matt mentioned, celiac disease is not included in this, in part because this study is based on the previous observation that there's an elevated risk for coronary artery disease in patients with celiac disease, because celiac disease is associated, so it's a very real and can be very debilitating disease. It's associated with inflammation in the gut that arises from exposure to gluten, and gluten is the protein in wheat, barley, and rye that contains most of the protein in the actual foodstuff. So they wanted to ask the question: is there an association between the amount of gluten that you take in and associated coronary artery disease? So what they did was to use these two cohorts. And they identified and followed them prospectively and looked at the exposure, which was the amount of gluten, as reflected in the questionnaire that they filled out on a every 2-year basis. And it looks like they only used the questionnaires that were available every 4 years, because they looked at data from 7 surveys over 26 years. And they enrolled 64,000 women from the Nurses' Health Study and 45,000 men from the Health Professionals Follow-Up Study without a history of coronary artery disease, who had completed a 131-item semi-quantitative food frequency questionnaire. And that was the survey that was filled out on a biannual basis, and from which they obtained the data every 4 years. Yeah.
Every 4 years, yeah.
And the exposure was consumption of gluten. The outcome was coronary artery disease, either an MI, fatal MI, or a non-fatal MI. Let me just
Heart attack.
Yeah, heart attack. Let me also mention that the mortality follow-up in the Nurses' Health Study is 98%. So their ability to follow these people, at least until death, is really quite remarkable. So based on the information that they collected on diet, as well as a whole host of non-dietary covariates that could potentially confound the finding of coronary artery disease, like race and age and diabetes and aspirin use. And they threw those into the analysis model, along with dietary covariates that also may be associated with the development of coronary artery disease, such as alcohol, trans fats, red meats, processed meats, et cetera.
All the usual suspects, in other words.
Yeah, all the usual suspects. And so over 26 years of follow-up, or 2.2 million person years of observation, there were about 2,400 women who developed a heart attack, an MI, and 4,000 men. And what they did is they, as we've seen before in these nutritional studies, is they broke it down into the lowest quintile and the highest quintile consumption for gluten, and then they compared the results for those. And they found that those people who were in the highest quintile for gluten consumption had 75 fewer episodes of coronary artery disease per 100,000 person years than the comparable lowest percentile group.
And that's in absolute terms, 75 per 100,000.
75 cases, right.
Yeah, per 100,000.
Right. And after they adjusted for 15 of these non-dietary factors and the dietary factors, there was no statistically significant association.
Okay, you're just toying with me.
I did. I couldn't help it.
You just want to upset me by saying that. Let's just say there was no meaningful association.
Right. And then they did sort of an interesting, tricky thing, which is what they did is they sort of separated out the source of the gluten, because gluten can come from refined grains or from whole grains. And so they controlled for the amount of refined grain and controlled for the amount of whole grain. And they determined that if you control for that, there does seem to be an effect associated with the consumption of whole grains, controlling for gluten, an association with whole grains in the development of coronary artery disease.
I don't think it was controlling for gluten. It was controlling for refined grains. In other words, they were trying to get at what is the source of the gluten? Is it whole grains or
right? So I thought that what they did is they held the gluten amount constant, and then they looked at the effect of of the whole grains versus the refined
I don't
grains.
think so. I think they held the source, one of the two sources constant, allowed the other to vary such that the amount of gluten is varying as the amount of the source is varying. So,
All right. So in any event, what they found was that there appeared to be an association with decreased coronary artery disease in the group that had a higher intake of whole grains.
Which is what we tend to believe should be the case.
Right.
Whole grains, generally, we assume that these are good for you.
Yeah. So their conclusion is the long-term gluten intake is not associated with coronary artery disease. However, avoidance of gluten may reduce consumption of beneficial whole grains, which may affect cardiovascular risk. The promotion of gluten-free diets among people without celiac disease should not be encouraged.
yeah, we're going to come back to that because I take issue with that statement specifically, but we'll come back to that. Let me just harp on a few quick things before I turn it over to Chris, which is I wanted to point out. So as you said, really large or a very large sample size here, 100,000 people, followed for a very long time. 26 years was I think the average follow-up time.
Total of 2.3 million.
2.3 million patient years of follow-up.
Amazing.
I also want to point out these are small risk events in this population. This is less than 1% per year events. So these are, I just want to have it in people's minds that we're not talking about a high risk event. I also want to point out that this was done, the data here started in the 1980s. So this was done before the
whole idea of the thoughts about gluten.
Thoughts about gluten really were gluten is bad, and therefore you can the data is at least not tainted by people's decisions to avoid gluten or eat more gluten because of diets that are being promoted now. The other thing I did want to point out is this is it's a very white cohort. I don't know if you saw the percentages, but it's about 98% among women and 90% men, which is nothing wrong with that in terms of confounding or anything like that. In fact, it probably helps in terms of confounding, but it just says that if we think about who this is generalizable to, this is largely generalizable to Caucasian populations. So, Chris, what's your take on this study and the quality? What's your critique?
Yeah. So I was impressed by the study, generally persuaded by the study. I want to start with the point you just raised because I think this whole issue about the public health meme that's surrounding gluten. So to sort of walk it back, gluten is without a doubt the cause of celiac disease. I mean, this is totally unambiguous.
Can't emphasize that enough.
Totally separate issue. So gluten, if you have celiac disease, gluten cannot be part of your diet because it is, harmful and possibly fatal. So we went from that, unambiguous statement to this sort of, modified popular meme, which has evolved particularly in the last 4 or 5 years, I would say, where there's this assumption that because gluten is bad in celiac disease, gluten is therefore bad in general and has all sorts of associated health effects. But you're absolutely right that thought, that sort of popular conception did not arise until around 2012, 2013, and has been growing. And they specifically limited their analysis to before that. And so the healthy user, the healthy belief effect should be stripped out of this analysis. And I totally agree with you. I thought that was a huge strength here that persuaded me.
I think it's also important to state that true celiac disease is very rare. It's like 0.7% of the population.
Yeah.
Whereas people who avoid gluten comprise now a very large portion of the population.
There was one statistic in here where they said about 30% of the U.S. population is now avoiding gluten.
I don't know how reliable that is, but it attests to the fact that it is certainly.
I mean, it certainly is ubiquitous.
I certainly come across many people who avoid gluten.
And it's not the same as saying that they're on gluten-free diets, but they are trying to limit gluten. And, let's be honest, there may be a reason to do it because gluten is almost, inevitably synonymous with carbohydrates.
Right.
And so, in a sense, we should be limiting gluten because it's a proxy for eating less carbs. But it's not the gluten per se. It's the gluten is found in wheat products, and we eat probably too many wheat products. Last night I was taking a shower and I noticed that my shampoo...
I'm fearful of where we're going.
You don't have to worry. But my shampoo and my conditioner were labeled as gluten-free. And I'm like,
Well-
this is public exhibit number 1. That is crazy. That is totally crazy.
I saw a photo on the internet. I don't know if it was real or just photoshopped of a house being advertised, and the house listing was listed as gluten-free.
Oh, come on.
Yeah.
That had to have been photoshopped.
I probably was, but I don't care.
My
I don't
daughter
care.
works
Made me
in
laugh.
My daughter works in a bakery, and people often come into the bakery and say, "Do you have any gluten-free products?" And she says, "We sell
Baked goods.
some baked goods where we do not put wheat in them, but this is a bakery, and there is flour everywhere.
Yeah.
So if you really have celiac disease, you should not eat anything in this building because you got to assume that there's contamination everywhere." Now, so this is sort of interesting evolution of a meme that leads to a new hypothesis. Meme. But like the interesting thing I thought was when I was like saying, okay, like, they start with this premise that gluten in patients with celiac disease are more likely to have cardiovascular disease. And so I was like, okay, well, where does that premise come from? And the hypothesis we see stated in the paper is that it leads to general inflammation and, there's, pro-inflammatory, pro-free oxidizing radical things going on, and that's therefore bad.
That's bad.
But I actually went back and pulled the original,
It's not bad.
or looked at the original papers, and the biggest one of these was a study published in JAMA around 2008, 2009, and it like the results from it were just perplexing. It almost felt to me like we ought to study that study as well, because it's sort of like, where did this meme come from? Part of it comes from this study where there was this bizarre relationship where they had biopsies done in I think it was in Norway or Sweden, and they had they graded the biopsies according to the degree of inflammation. So the people who had full-blown, really severe celiac disease, like grade 3 and 4, like inflammatory lesions were in one group. And then you had people who had like mild inflammation. And then you had a third group of people who had no inflammation at all, but had positive antibodies that are associated with celiac disease.
Yep.
And the patients in this cohort who had the most severe celiac disease, their risk of coronary vascular disease was about a third of that who had the mildly inflammatory disease. So you're sort of thinking like the degree of inflammation correlates to the degree of cardiovascular disease. That relationship was not shown at all, which seems like that kind of defeats the argument that it's sort of this inflammatory state that leads to this.
Yeah.
Yeah. So I don't know. I think this is a good study. I think it kind of encourages me to eat more whole wheat, which I like anyway. So it's not a problem.
It's good for you.
But it does burst the bubble that there's a big bad consequence to eating gluten, at least in terms of heart disease.
Maybe.
I have a problem with this in the same way that we have problems with a lot of the nutritional studies, because it's all recall, and it's recall of what your dietary habits are over the course of the last 2 years, essentially, and they only picked data from every 4 years. But what was nice about it was that in the analysis they did these covariates as time-dependent covariates. So they would sort of revise the role that those covariates would have in the equation every time there was new data coming in. So it wasn't that it was really the effect of the covariates at baseline or 15 years ago. It was sort of revised as it went along. So I thought that was sort of a strength. But still, I think the underlying problem with this dietary recall is a problem.
So I want to raise a couple other issues, which is what is the potential here, do you think, for the uncontrolled confounding? By which I mean the confounding that is left over when you control for the things that they did control for. And they controlled for a lot of stuff. They controlled for a lot of stuff. However, we know that, as you just said, those things are mismeasured. We know that you can't get an accurate measure of, all of these different makeups in the diet over time. And therefore, any confounding that's going to be created by these factors is only going to be partially removed when you control for them, when you put them into a statistical model. It's just the nature of doing these kinds of studies. What I thought was interesting was, for whatever reason, and remember we said that this was done in the era before there was the awareness of belief that we should be avoiding gluten. But if you actually looked at it, a low gluten diet, low gluten, so not avoiding gluten, but low gluten diet was associated with healthy behavior. So it was associated with less alcohol, at least this is what I took away from it. It says you have less alcohol, more whole grains, less processed, less red meat, can't remember, less smoking. And so if that were the case, if less gluten is associated with healthier behaviors, when you control for that, when you don't control for that, you would expect that if those are healthier behaviors are also protect you from having heart attacks, then you might see a protective association of low gluten diet, which is what they saw in the raw data.
Okay.
They saw a protective effect.
In the unadjusted, right.
In the unadjusted.
Yeah.
They then adjust for it, and the effect goes back towards no effect, which suggests that if you could fully control for the confounding, in fact, it might go further, back into the harmful area. Now, we don't know, right? We don't know how far it would go. We don't know how much residual confounding there is, but I just thought it was interesting that when you look at the direction that the confounding correction goes, it goes from protective back towards the null. Additional adjustment for things that we know are likely non-differentially misclassified should take that even further. How much, we don't know. Whether it's meaningful, we don't know. I suspect it's not meaningful, but
trouble is, it leaves us in the same place that where we find ourselves a lot of times when speculating about these large data sets that collect nutritional data, because you can't design a study that's going to really address the issue that you're bringing up. So, it is speculative. But we just, unless you are recording the dietary intake of a large population of people prospectively over a really long period of time, and that's just not a feasible study to do.
Yeah, Matt, can I ask you a question? Because we're in the opposite situation that we're usually in. The problem is analogous, as Don's pointing out. Usually, we're looking at an article that is asserting an association, which we believe is due to confounding or bias.
Sometimes,
And here you're hypothesizing that we have no association as the bottom line for the study, and we're hypothesizing that there might be harm or benefit that's hidden. And I guess I'm curious, in your experience, how often how often do you see a null effect transition into a positive effect, either harmful or negative, it doesn't matter, but as opposed to the converse.
So now I get to make a plug for quantitative bias analysis, which is what I have spent a lot of time working on, mathematical ways of trying to assess the amount of assess the impact of unmeasured confounding or uncontrolled confounding like this. I don't know the answer to that. It's entirely dependent on the strength of the confounder and its relationship to the other factors that you're looking at. I would say, looking at this, if I were to guess, and it's just a guess, is that if you were to keep moving that effect, it would sort of stretch over into the mildly harmful area, not into the particularly harmful area, such that we'd be concerned. I'm just saying it's one of these things that I think it's worth noting that the logic to me says that if you continue to adjust this, as you probably should, it's probably going to go in the harmful direction. But again, remember, we're talking about small effects, a small low risk event. Therefore, small effects would be such that you might not change you certainly probably wouldn't change your behavior. So I don't want to overstate it. My second issue is I do wonder whether if there is any harm going on here, that it's in a distinct, a small subset of the population that is getting overwhelmed by, as Chris says, the fact that other people are being harmed by avoiding whole wheat in their diet, which is where they're getting their gluten from. It could be that if there is a subset of the population for whom there is real harm strictly from the gluten, that's getting masked by any harm that is being caused in probably a larger set of the population by avoiding whole wheat. But really don't know.
That's a whole host of really subtle issues. I mean, I guess I want to try to bring this back to our listeners here. And try to
Do we have any?
We used to.
The listener, the one from Gabon.
The guy from Gabon, right? Or is it
Seychelles?
Togo? I think it's Togo.
Togo.
So basically, what we're saying, I think was what we're saying, is that we're looking at a clinical question that has sort of emerged almost organically as a sort of indirect stepchild of celiac disease and its association with gluten, which is crystal clear and absolutely true, and has just become a hyper-marketed phenomenon that gluten bad, whole sections of the supermarket are gluten-free, shouldn't eat gluten. People think, therefore, they should not eat gluten and are obviously starting to feel guilty about eating gluten.
I don't feel guilty.
Neither do I, because I love croissants. And I wish I could eat more of them.
No one's stopping you.
Yeah. But if we step away from the sort of the popular interest in this issue, and we start with what is the a priori probability that gluten per se, as opposed to carbohydrates, which are packaged with gluten in the wheat, are a problem, the biological plausibility of that to start with is very, 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 very low. And so now we have a study that shows, indeed, there is no evidence based on this large population survey that there is a risk. And therefore, our low likelihood of probability of this theory being true is now further diminished by this massive study that says there ain't nothing there. It's complicated.
Does anyone want the second to last word before I get to give my last thoughts?
No, go ahead.
Eat your Wheaties, Matt.
Eat my Wheaties. Okay, I'd like to point out a few things about this article, as I always do. First of all, I'd like to point out that they did exclude anyone in this study who had angina.
Angina.
Okay, so things that interest me. So this is one of my pet peeves in articles in general. They tell us that we use SAS version 9.4 for all analyses.
Yeah, who cares?
We should do a whole podcast segment on this because I've never understood, unless there's something unique about the particular program, subset of SAS.
Did the chi-square change between versions 9.3 and 9.4?
No, but I do think it's important that they tell us where the manufacturer's based.
Cary, North Carolina.
Well, I've never said
they drove past there when I was in North Carolina. I was so excited.
Every time I see it, I assume the next line is going to be, and we wrote the first draft in Microsoft Word.
Right.
And I've never
Apparently,
understood.
it's one of the best places in the country to work.
Why doesn't SPSS get bent out of shape about this? SPSS version X. I mean, no one ever says that.
I don't know.
What's wrong with SPSS?
Okay, second. The statement, they say no patients were involved in setting the research question or the outcome measures, nor were they involved in developing plans for recruitment design or implementation of the study. And it goes on. I'd never really seen anything quite like that. And I suspected that was... They were asked to put that in. I just wondered what that was all about. Anyway, that's not particularly important.
As these stories are decades, these studies are decades old.
Yeah.
It would be highly unlikely that they would have been.
And then the last one I want to get to, which is the point you raised in the beginning, Don, which is that they make the statement, and it's actually in the abstract. It's not just in the paper. In the abstract, promotion of gluten-free diets among people without celiac disease should not be encouraged. And based on the results of one study, as you know, I'm not a fan of putting policy statements about our work into our manuscripts to begin with. But based on the results of a single study to go that far and say, therefore, we know this is bad. Just strikes me as going beyond exactly where the science can go at this point, and certainly does not belong in the abstract. So that's just my.
They're overselling a tiny little fragment of the analysis.
Yeah, I mean, they could have qualified it by saying with respect to cardiac disease,
or just said nothing. I mean, it just let's wait till there's other studies can confirm this. Particularly given the limitations. All right. So, can we move on?
Yeah. Sure.
Can we act like grown-ups?
No.
All right. So, in our second segment, we want to talk about what the role of prior beliefs and prior evidence should be when we judge an article. So, when it comes to statistical inference in epidemiology, there are generally two schools of thought. There are the frequentists and there are the Bayesians. So the frequentists are the people frequentists are the general statistics that we normally think of in the medical literature. But there is another school of thought that are Bayesians. And Bayesians take a different approach. Frequentists would generally say, essentially, that I'm going to run a statistical test, and based on that, I can draw conclusions about the effects that I'm observing in my study. Whereas a Bayesian would say, no, I can't draw effects solely based on the results of my study. I also have to think about what did I believe before I ever did the study, and what does all the evidence tell me? So in other words, if there were 1,000 studies that looked at the relationship between driving 100 miles per hour and developing cancer, and every single one of them found no effect, and then you did the 1,001st study and it did find an effect, well, a frequentist approach would say it's statistically significant, therefore somehow maybe it's meaningful. Whereas a Bayesian approach would say, let's look at the 1,000 other studies which found no relationship. It would take a lot more evidence than just one statistically significant result for me to take notice. So that gets me to thinking about how we go about critiquing and how we think about our role here on this panel, but our role in general as we look at the body of evidence for or against a particular exposure outcome relationship. Is it our mandate, should we be checking our prior beliefs at the door when we critique an article? Or is it fair game to say, I go into this article completely skeptical, and therefore it would take a lot to convince me otherwise? And I should say, I had a prior belief when I read the gluten study. My prior belief was there is no effect. Now, I actually am convinced there actually may be a tiny effect. But going into it, my prior was there was no effect. And so it was going to take probably more to change my opinion. And the question is that fair? Or, is it my job to remain completely objective when I'm critiquing a study as just a consumer or as a reviewer of a journal article or, when I'm trying to synthesize the evidence? What do you guys think?
Let me just clarify one thing. You think now, after having read this article, that there's a tiny effect,
No,
of gluten.
Sorry. I'm open to the idea that there could be. No, even of gluten. I am open to the idea that there could be some tiny effect. I'm not saying there is.
Despite the findings in this particular paper.
Yeah, because of my concerns about potential residual confounding. But I'm not saying there is. I'm just saying I'm open to it. But I doubt it's a big effect.
Years ago, I think I got a PowerPoint slide for you, which I have used in many lectures. I think you created it. It was a line graph looking at changes in two events over time. So it was one of like your wacky correlation things, like sort of pointing out that correlation does not equal causation.
Yep.
And the title of the graph was like annual average surface sea temperature and the number of pirates.
Yes, that was me.
Right, that was you.
That was me.
It felt like a Matt Fox slide, and I have loved that slide, and I've used it ever since.
Pirates do control sea temperature.
And so, you could say, the pirate number is going up as the sea temperature is going down, or the other way. It doesn't matter because the plausibility of pirates having anything to do with sea temperature is just ridiculous.
Yeah.
Okay. So that we can dispense with that. And that is a perfect example of your a priori assumption, your prior saying there is no plausible way that the number of pirates can increase the number of the sea temperature, or vice versa.
Decrease.
And so, right. So, even if you see data that seems to imply this inverse correlation, you're going to go, whatever, like that's just nuts. And so what I did subsequently in my lecture was to take exactly the same figure that you used and change the titles of the axes
to
pertussis rates and DPT vaccination rates.
DPT meaning the vaccination for against
diphtheria, tetanus, and pertussis. And
so to have his diptet.
Right. So exactly. So now you could say that the increase in pertussis vaccinations and the decrease in pertussis disease are very likely to be true. But the data, the slide, is identical.
Right.
Okay. And so the point I'm trying to make to the students, which I guess I'm trying to get across here, is that the only thing that distinguishes those two pieces is not the data, it's the prior.
It's what we believe.
It's what we believe.
Before we saw
and
the
so
data.
When we do a journal article, I think we go through a series of steps. We have to begin with a prior. We have to have a general assumption, like you said. I don't think that there's a relationship between gluten and heart disease in people who don't have celiac disease. And then you see the data, and the data in this case show that there's no association. So you'd be entitled to say, I'm more convinced that there's no relationship than I was. And so I think, it's not that we are modifying our opinion of the data. All we're doing is starting from a different place, and that the data stand constant. It's moving you along some spectrum of probability of truth. And the important thing is where you began on that. Now, where this gets really wacky is that it's very hard to know really where you begin. And that's where the whole argument about Bayesian reasoning becomes. Like, how do you define that prior? What is what is the belief, particularly when we're talking about something a little bit new, like gluten and cardiovascular disease? It's complicated.
Fair enough. I mean, my general approach would be to say if it's something new, we want to remain pretty skeptical about it. And because, if certainly there probably are, if it's brand new and we're not observing, associations that we would just pick up by surveillance, then the effects are probably not massive. And so I would sort of remain a little bit skeptical until I had reason to believe otherwise. But anyway,
Right. It's sort of like what we said during an earlier podcast, which is that
you listen to us?
no, I just have a good memory.
Oh, wow.
It's that what we want to do is we want to put the findings of a particular paper really in the context of everything else that has happened
Exactly.
in that sort of topic area. And so one positive finding does not, truth make. So that in essence is a different way of looking at this kind of a priori. It's not bias, but it's really a preconception that you have. And I think one way that I think about how this really operates is it's essentially what a physician does at the bedside. So when a physician comes in and evaluates all of the data that is collected, the vital signs and the physical examination and the history, it may lead to one of a series of conclusions. And what the physician does is puts their prior experience with the constellation of data that you're collecting about this patient into the context of their experience and coming up with a conclusion about what's the most likely outcome. So it's I think it's kind of similar in that way.
Yeah, I mean, so the example I always hear is that if somebody comes in with a headache, you don't assume brain
meningitis.
tumor. You don't assume meningitis because it could be.
Right.
But the prior probability suggests the more likely event is
and there's
a headache.
Stress. There's a very
Science.
sort of well-worn expression in medicine, which is when you hear hoofbeats, think about horses, don't think about zebras. Because the likelihood is that the hoofbeats that you hear are due to a horse, because horses are much more common and makes more sense, rather than zebras. So if you come upon a finding, if you're confronted with a finding like a headache, you're not going to think of the rare occurrence like meningitis or brain tumor. You're going to think of, well, it's a headache.
Yeah, right. People dime a dozen.
So that's all well and good, and I think we all are in agreement there that is how we should be thinking about integrating new information. But now go back to my specific question, which is it okay then to go into a critique of a paper that way? Because my worry is if we go into a paper with an idea that I already don't believe it, or I definitely do believe it, that I'm either going to find things to rip it apart, or I'm going to find things to bolster its credibility. How do we?
I think we have to go into it with skepticism. I think we have
this
to go.
is bizarre because I just want to let the listener know we had this conversation yesterday to get ready, and you and I both took the opposite opinions. This is bizarre.
And now we slept on it.
Apparently, both of you convinced each other.
Okay,
We did.
convince me back. Get me back to where I was. Go ahead.
I'm rock steady here,
We
guys.
gotta, Chris is Switzerland here.
No, I think it's important that you go into this with a healthy degree of skepticism, but you can't check your preconceptions at the door because I think it's just almost not possible to do. But I think that you have to evaluate the evidence that's presented in the paper as objectively as you possibly can, and then when you get to the point of the bottom line, like when you ask Chris or you ask me, all right, bottom line, what do you think?
Yeah.
You have to put that into the context of both your experience with the science or your experience with the particular discipline.
Yeah. I mean, there's a tricky nuance here, right? Which I think is what you're getting at, is that suddenly some journal of physics publishes a study showing that this guy dropped an apple, let go of an apple, and it flew into the sky. Okay, so gravity is wrong, and it's been a coincidence up until this point.
Yep.
Right. Okay, so
It's David Copperfield, right?
We can't. Or like the talking horse who does math tricks. I mean,
You're not going to tell me that's wrong.
it is wrong.
The horse?
The horse doesn't actually.
The
do
horse
math.
can't talk?
The horse can talk, but it can't do math.
What about Mr.
They
Ed?
can count, but they
Mr.
can't.
Ed could do
They
both.
can't do calculus.
Okay.
All right.
Go ahead.
Anyway, the point
Continue.
is like when you go in, when you see, a study saying something that is totally preposterous. I mean, it is very, very, very difficult to be completely objective. Instead, what you go into that study doing is like, okay, this has got to be wrong. Where is the mistake? And so I think that's where you're getting it, is that it's hard to be completely objective because you are immediately suspicious that something's wrong. Something's fishy here. Where's the lesion? Find the lesion.
Okay, but so then fair enough. And if that's the case, then what do we do in the cases where we consistently got it wrong? the example we always give, and I always put the caveats on it, is the hormone replacement therapy and heart attacks, which we got wrong in the observational studies for so long, or maybe we didn't get it wrong, but let's just assume for the moment that we did. You would say you got a study that says actually it's harmful. You would say, well, that's just not plausible. And then I'm going to go in and find reasons to dismiss that study, whereas that actually is a study that was right. So I'm not sure we're always right when it comes to plausibility.
Science is dynamic, and we have to accept the fact that science is dynamic, and new things are discovered, and new paradigms are elucidated by new evidence. And I think we both have to be very skeptical and logical, but we also have to be humble to understand that our prior conceptions may be wrong.
Yeah, this is what Thomas Kuhn is talking about in The Structure of Scientific Revolution. So this is very phenomenon that there is a prevalent belief in the scientific community that this causes this. So this is the way. This is the model of how something works, and everything up to that point is sort of lined up with that belief, and then something new comes along and challenges it. And the response by the scientific community is to be very stubborn and to deny and to look for ways to maintain the model, because the prior model had done so well at explaining everything we'd seen, and yet and in many cases the new data turns out to be false, and so the prior model was right, but sometimes it's not false. And there's a paradigm shift. This is where it pivots. And it would be lovely to think that this happens in sort of a rational, clean, systematic way. In fact, I think it happens in a much more chaotic way, and that this sort of movement towards truth is much like the stock market. It's bouncing up and down, and sometimes there's corrections and sometimes there's a boom. And things change.
It kind of depends on the preponderance of evidence.
Mm-hmm.
I think there are very few people that believe that the theory of relativity is about to be upset. That every time we get to the point where we can measure something like gravity waves, it confirms something that is a very solid. I think it's accepted in the scientific community as truth. Now, and there's a gradation between that and stuff that that isn't quite so sound and does change.
Yeah, I don't know the answer, but I will say this: I think we have an obligation to try at least to separate out the steps, and I swear this is the statement you made yesterday when we had this conversation, and I actually now believe it, that we have to kind of separate out these two steps, that the art of critiquing a paper.
That was Chris said that.
No, that was you. The critiquing of a paper,
under the bus. We
should try to remain as objective as we can when we're actually critiquing it. Then that's different from saying, what's the conclusion that I'm going to draw from this particular study, where I might say, okay, the study is pretty good, but still within the body of evidence, it just doesn't hold up to what I think. It doesn't move the needle or move me enough.
More research is needed.
More research is needed. All right. Well, I will. I want to wrap this up. It does not answer the question of what the right approach is, nor whether Bayesians or frequentists are the right approach. But I did want to end with this because I saw this on Twitter. Apparently, there is a Twitter account for p-value, and there is a Twitter account for Bayes factor. So p-values being the frequentists and Bayes factor being the Bayesians. And apparently p-value has more followers than Bayes factor. So
get a life.
I clearly p-value, apparently the frequentists are more popular.
Can I make the point that the two are not mutually exclusive?
Which ones?
Bayesians and frequencies. It's not at all exclusive. That you can, if we're seeing the review of the interpretation of a study as a you start with a prior, then you look at the data, and then you have a posterior. The application of frequencies and statistics within that study does not negate the fact that the whole process of changing your opinion is in fact Bayesian. There's a distinction here between Bayesian statistics and sort of the application of Bayes' theorem in a more general sense. And I think when you start with, I think that this hypothesis is likely to be true based on all these studies, then you see one more study analyzed with p-values and hypothesis testing according to the standard frequentist approaches, and then you change your posterior. That is Bayes' theorem in a nutshell, even though you didn't actually use in that study any Bayesian statistics at all.
Fair enough. At least I buy at least the logic. All right. Well, we're not gonna solve this one, but let's move on to our third segment. So that's our Amazing and Amusing, where we want to highlight some of the things that make us enjoy our jobs even more than we already do. A look at the weird, wacky things that happen in our field, and in Chris's case, often the things that inspire us. So Chris, what do you got for us this episode?
Yeah, so on this one, I went back in time, and I was trolling around, and I stumbled across this reference to an early elegant paper published in, it might have been the British Medical Journal, but I'll pull the citation afterwards, about varicella zoster virus and shingles.
So chickenpox virus and shingles.
So the varicella zoster virus is called that because when kids get exposed to chickenpox, they break out in this generalized rash, which we call chickenpox, and that decades later, there is a proportion, actually about 50% of individuals who reach the age of 80 will develop shingles, which is a chickenpox-like rash that occurs in like a stripe corresponding to a single nerve root. Now, it's interesting because 50, 60 years ago, it was not known that this was true. And the history behind how we now know this to be true and the sort of the pathophysiology of varicella zoster is really interesting. And it was really pushed by this very smart self-taught epidemiologist / clinician called R. Edgar Hope Simpson, who you probably heard of Hope Simpson, who did all these studies on early pediatric infectious diseases like measles and chickenpox and mumps and things. And he was working in his primary care practice, basically collecting data on approximately 3,500 of his patients over many decades who had had shingles, and used this data set to sort of probe the three hypotheses about what is shingles?
Hypotheses?
Hypothesize. Hypotheses?
Okay.
So, like, to sort of, summarize the evidence to that point, the fact that shingles occurs in a dermatome, was a clue that even back in the 19th century that something was happening along the path of a single nerve. So later on, during doing autopsy studies, they found that people with shingles had inflammation in the nerves that fed that skin territory, and also in the basal ganglia by the spinal cord, the sensory nerve ganglia and the spinal cord also had inflammation, so it hung together. Much later, it was found that in those lesions, you often found clusters of protein that anagenically, based on staining with antibodies, looked like it bound to chickenpox antibodies. And so, the question was, is this a chickenpox family virus or is this chickenpox? And eventually it was shown that, in fact, the viruses you find in chickenpox lesions in a kid are identical to the ones that you find in someone with shingles. And so this is like a great mystery. So the idea that the chickenpox virus could be hiding in the spinal cord and emerging along these dermatomes was what's hatched. But there were really three theories that Hope Simpson wanted to attack. The first was, do you get shingles by being exposed to someone with shingles? And he could answer that question in his 3,500 subjects over many decades, because you would expect, if that was true, that there would be clustering in time and space. And there wasn't. It seemed to be totally random. So the question number two is, maybe you get shingles if you're an adult who's exposed to chickenpox from a child with chickenpox. But if that were true, then shingles would follow the chickenpox epidemics, and it didn't. So the third one was that this was a latent infection caused by exposure to chickenpox when you were very young, and that the virus had then hidden itself in the nerves to sort of hide away from your immune system. And we now know this one is correct. And the beautiful thing that Hope Simpson provided in this was a hypothesis as to why this might have happened. And his theory, which I think this is very plausible, was that this harkens back to a survival mechanism by this virus to figure out how to perpetuate itself in hunter-gatherer societies. So chickenpox is very infectious, and it lasts a very short period of time. When you have 10 days, 20 days. So if you're in a hunter-gatherer group of, say, 400, 500 people relatively isolated from other populations, that population size cannot sustain chickenpox transmission. It will go extinct.
Through the whole population, and there'll be nobody left.
And there'll be no one left. And then, and so in order to sustain it, you need an evolutionary strategy that allows you to skip generations.
Very cool.
And by hiding out in the nerves, and then reemerging sort of somewhat randomly 4 or 5 decades later, this is how you skip generations. You keep chickenpox going, even in very small populations.
So that would imply that somebody with shingles can transmit chicken pox
And
to
they
an
absolutely
uninfected
can. We know
child.
that happens all the time. My daughter got chicken pox after hanging out with her grandmother-in-law. This is my in-law's grandmother who had shingles.
Wow.
And then she got chicken pox right afterwards.
Very cool.
So
not that part.
Yeah. So I mean,
Whole thing.
Anyway, this was considered to be one of the best scientific papers. It was read to the Royal Academy.
Very cool.
Coming from a primary care physician who never took a course in epidemiology and just basically taught himself.
Logic.
It's really cool.
Very cool. Don, what do you got for us?
All right. Going from the sublime to the ridiculous, which is
As we tend to do.
as we tend to do, I managed to pull a paper from the journal, the estimable journal, Sustainable Production and Consumption. And the title of this paper is Understanding the Impact on Climate Change of Convenience Food or the Carbon Footprint of Sandwiches.
The carbon footprint of sandwiches. Got it.
Carbon footprint of sandwiches.
Whole wheat or
So this team looked at 40 different sandwich types. This is a group, Naomi Espinoza Orias and Asa Pajic from who did the work in Britain. And apparently sandwiches are quite popular in Britain. And in fact, there is a British Sandwich Association. I had no
obviously.
idea. It must be next to the Directory of
it
Funny
linked
Walks.
to the Earl,
Ministry.
Earl of Sandwich.
Ministry of Funny Walks.
The Earl of Sandwich.
They don't mention the Earl of Sandwich, but apparently there's more than 11.5 billion sandwiches consumed each year in the UK alone. And they did a deconstruction of everything that goes into the making of a sandwich, both the kind,
When you make it the right way.
both the kind that you make at home and bring to work and the kind that you purchase. And they went through 40 different sandwich types, recipes, and combinations. And they found that the highest carbon footprint for the sandwiches with pork, meat, bacon in particular, ham or sausage.
No,
and
can we cut that?
Those containing
cut that?
cheese or prawns had the highest carbon footprint.
Sorry, you said what? Tofu there?
No,
Is that what you
not
said?
tofu. No,
Tofu?
no.
Tofu, that's what I
Not
heard.
tofu.
I heard tofu.
bad.
No, prawns.
What about
so-
tempeh?
But apparently, they calculated that these 11.5 billion sandwiches annually consumed in the UK generate 9.5 million tons of carbon equivalent to the use of 8.6 million cars. That is a huge carbon
Wow.
footprint for sandwiches.
Sandwiches are causing global warming.
Well, they looked at the agricultural production. They looked at the energy used in chilling them in refrigerators and stores, as well as the carbon footprint of the packaging. And they
Wow, that is depressing.
I am not going to
We're
be able
eating
to
ourselves into planetary destruction.
Well,
They concluded the carbon footprint of the snacks could be reduced by as much as 50% if a combination of changes were made to the recipes, packaging, and waste disposal. And I think what they're advocating is that they're advocating for cucumber sandwiches with the crusts cut off for everybody.
well, obviously, you got to cut those crusts off.
What if we only drank like orange crushed soda and ate potato chips? Would that be better for the planet?
We could go through the
It's got to
calculations.
be. It's got to be. I'm sure we can find a study that demonstrates that.
We should
Absolutely.
look hard tonight.
Absolutely. All right. Well, I'm going back to a familiar topic that I like to harp on. I will say that this came off the internet, so you can't. I cannot say for sure that I can verify that it's a true story, although it appears to have come through an interview on a reputable website. So I'm going to assume it is true, and even if it isn't, I'm going to believe it anyway. So this is the story of Professor Ollie Daub, D-A-U-B. Is that how you pronounce it? Daub?
Mm-hmm.
I don't know. Who at one point sat on the board of 7 different medical journals. 7 different medical journals. There was only one problem with Professor Daub, which is that Professor Daub was a dog. So he was the dog of Mike Daub, who was a professor of health policy at Curtin University in Perth, who was tired of getting all of these, emails from journals saying be on our editorial board. So he made up a CV for his dog.
No.
Sent it in. Again, I'm just telling you. And what he said, he was interviewed. and says,
Oh, the dog?
well, I assume so. No, the professor was. He said what makes it even more bizarre is that one of these journals has actually asked Ollie to review an article entitled, and I won't give the title, some poor soul has actually written an article on this theme in good faith, and the journal has sent it to a dog to review. So further proof that these
If you're on the
predatory
internet,
journals...
nobody knows you're your dog.
So does this dog know how to count and do math?
I don't know the answer to that, but I assume so because I know that horses can, and therefore, why can't a dog?
That is a refutable argument.
All right, well, you've made it to the end of our program. If you've got any feedback on this or any other episode, or you want to suggest a topic for us
Keep it to yourself.
to take on, you can tweet us at @PopHealthyX, or you can tweet me at ProfMattFox, or you can tweet Chris at ID.Gill, or you can tweet Don at DThea1 and he won't even see it, or you can find us on the Population Health Exchange website at www.pophealthyx.org. We want to thank Leslie Talalian, Director of Lifelong Learning at BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode.